Good afternoon, everyone. We'll get started. Welcome to today's webinar. I'm Barb Kabilis. I'm the Regional Stroke Education Coordinator. And this afternoon we're lucky enough to hear the presentation from Dr. Oczkowski, A Holistic Approach to Stroke Care Using the Post-Stroke Checklist. Wes is planning to speak for about 45 minutes or so, and then we'll have time for questions. Please put your questions in at any time into the Q&A or the chat box. I'll be checking both Q&As for the questions. I will be putting the evaluation for today's workshop. I'll put a link in the chat box as well. This presentation today is part of the Central South Regional Stroke Program's Continuum series. We are following the continuum from hyperacute to acute to rehab and community. Today, we're really looking at the transition between acute care and rehab. And Wes is going to be talking about the post-stroke checklist and how we can implement it there. I think we can get started. I'd like to introduce Dr. Wes Oczkowski. Dr. Oczkowski is a professor in the Department of Medicine at McMaster University, and he is a stroke neurologist at Hamilton Health Sciences. He is presently the medical director of the Central South Regional Stroke Program and the academic head of the Division of Neurology. Dr. Oczkowski is most proud of his contributions to undergraduate and postgraduate education at McMaster, advancing research in stroke, and particularly his leadership of the Central South Stroke Program for over 20 years. Welcome, Wes.
Thank you, Barb, for the introduction, and welcome everyone to this presentation. I'll try to end at probably 50 minutes. I think my overall presentation is a little bit longer than 45, but we'll go through it. I have, let me just, next slide, just a second. I have no conflicts of interest. This is my disclosure slide. I mean, I have received, not recently, some workshop honoraria for presenting at the Northern Ontario Medical School and elsewhere. The objectives today are to spend most of the time actually reviewing the components of the post-stroke checklist and related evidence. It's one of those things that seems like it's mundane, and but when I hand it to my fellows and residents in the stroke prevention clinic or working with me on stroke, it's found to be this unbelievable list of things that we really should be going over with every patient. I'm going to discuss in particular the supporting the evidence behind the post-stroke checklist, and then also to look at its utility based on the Canadian Best Stroke Practice Guidelines and recommendations. So I like to always start with a case, and this is Amanda, and I still see Amanda. I remember Amanda when she came in. She's a 42-year-old woman with a background of hypertension, and that's it. Otherwise, very healthy, mother of children, working, driving, completely independent. And she came in as a stroke activation and was found to have this intracerebral hemorrhage over here in the left side of the brain. And this is the MRI done a number of months later, which shows that the hemorrhage is gone. There's a little slip left over, the residual damage. Amanda did very well. She was otherwise healthy. She regained the power of her arm and leg, quickly became ambulatory, went through our rehab program, went out to the community, was doing post-discharge rehabilitation in our outpatient services. And I saw her in follow-up about 2 or 3 months after her stroke. And she had a number of things that were still not right, some of which included lack of energy and fatigue. She had tightness in the arm, a lot of pain in the arm and the leg and the face. Her bladder function wasn't quite normal. She had urgency, and she was scheduled to see one of our urologists. Her ability to walk was getting pretty good, but she used to be a runner and she couldn't run. And she wasn't at this point in time driving. So her NIH stroke scale score was actually quite low. It was just a couple of points when you examined the actual impairments she had, but her overall problems that she had as a result of the stroke were actually many. So one of the things that's useful, and this is, I should use this more often, I'll be honest, when I see patients in follow-up after they've had a completed stroke, is this post-stroke checklist. I'm a firm believer in the checklist manifesto as published and written by Atul Gawande, that it's an important aspect of our medical care, that we should use using checklists more than trying to rely on our memory, which can only remember 3 things at once. This is more than 3 things that we should review with our patients. And not all patients that come to you will remember everything. Not every patient comes to you with a list of things that aren't right. And so a checklist is actually an important tool that we can use. So one of the things that the major thing that the stroke prevention clinic deals with is really for people who usually haven't had a stroke, the stroke prevention clinic. Those people who have a stroke end up in our stroke unit and go through our rehabilitation programs and our outpatient rehab programs and are in the community. And the focus of a lot of the acute care on our acute stroke unit and the focus of the stroke prevention clinic ends up being this stuff. Which antiplatelet agent, dual antiplatelet agent, which anticoagulant, maybe a DOAC. Are you lifestyle modification? Are you exercising? Is your cholesterol under control? How's your diabetes? How's your blood pressure? And the visit often ends with that. And as our stroke prevention clinic nurses who engage our patients along with the physicians and would say, actually our patients who've actually had a stroke, and even if it's a minor stroke, come back and they have all these other problems. It's not just about these drugs and about not smoking and and exercising. There's much more to it than just this stuff, which in some ways is actually very easy to tackle. And this is only about 3 to 4 things that I have to remember as a physician, and I don't really need much of a list to be able to deal with these issues. But there are many other things, and some of them, for example, we'll go through the checklist, and I'll show you the evidence behind the checklist and why we need to think about these things more so than not. They're not always straightforward, and we don't always ask our patients about them, and our patients, as I said, will not come to us and tell us about them. Activities of daily living, that means this ability to take care of yourself, eating, grooming, bathing, dressing, continence, and mobility. And you can go through these. And why is it important to go through these? I mean, in the outpatient and in the community, haven't our rehab services done this already? Haven't they taken care of this? Well, one of the things that is, and actually I didn't know until I was reviewing the literature again, is that 1 in 6 people, in fact, they may be discharged well, and they in fact get worse after their discharge. So in this study from the Swedish Stroke Register, where they looked at 64,000 patients, and they looked at these individuals, and they found that there's a high proportion, 1 in 6 became more dependent. They were initially independent, became dependent within 3 to 6 months after their stroke. Those people that became dependent were people who were diabetic, who had atrial fibrillation, who had a hemorrhagic versus an ischemic stroke, and had a previous stroke. So that one of the things, the take-home message is when you ask about these ADLs, it doesn't mean once they've achieved independence that they're going to maintain independence. And this has to be reviewed on every visit and with our patients, because 1 in 6, which is actually a large number, being independent become then dependent, and this needs to be readdressed as to how to regain their independence. The next question in the post-stroke checklist is, are you finding it more difficult to walk or move safely from bed to chair and so forth? There are many types of movements, and I've sort of listed them above here. There are transfers from chair, bed, toilet, indoor walking, aids or no aids, indoor walking, stairs, and access to different floors of the house. But there's also outdoor walking on the sidewalk or on rough ground. And there are very complex transfers into the car, into the bus, and into a plane. which are all things that need to be taken into account when you look at somebody moving or walking. It's not just walking ordinarily on a nice surface indoors. There's all kinds of things. And the important thing about addressing this issue is about falls. And one of the things that that happens is that a lot of individuals fall. So in this study, where they looked at community participants, 231 who were discharged from rehabilitation, the highest risk time for falling is in the first month after post-discharge. 14%, more than 1 in 10 individuals had a fall after discharge. And then over the next number of months, there was a lesser risk, but there's an ongoing 10% risk of falling over the next number of months. So, and falls are a very dangerous thing, especially when we talk about our older stroke population, because if you know the falls and the hip fracture literature, when somebody has a hip fracture, there's a huge probability of hospital admission and mortality associated with a fall/hip fracture. So the other part that's very difficult when you look at the totality of the stroke literature is that it's difficult to distinguish people after their discharge from fallers versus non-fallers. A lot of work needs to be done about that. The other part that is, well, can we identify those people in the community who are potentially going to fall, or what things can we do in the community? If your patient comes to you and says, I have had a fall at home, what should we be looking at in the community with these individuals? And this large meta-analysis systematic review of falls after stroke and community stroke survivors, what did it identify? Well, your high-risk patients are going to be who? Those patients who already have been identified as having mobility and balance difficulty, those who require assistance of self-care as opposed to those who are independent. It makes sense. Those who have a better stroke recovery. But also the other things we need to look at is to make sure they're not on sedative and psychotropic medication. Who else is at risk of falling? Well, those with cognitive impairment. And what I would put in that are those with non-dominant strokes who are unaware of their environment. Those individuals are at high risk of falling. And it is very clear, if you had a fall, your risk of falling is much higher. And so that these things should be looked at as another little checklist about those individuals who you see who have had a fall, because falls are actually in the older population, very high morbidity, mortality problem. The other thing that patients may or may not address with you are, do you have increasing stiffness in your arms and legs? I.e., what we're asking them, do they have spasticity? Spasticity is a very common problem. If you look at the totality of the literature, it would say that it happens between 30 to 80% of stroke survivors. It doesn't happen in acute care, and it may not even happen in the early phases of like early rehabilitation inpatient care, because it peaks at about 1 to 3 months. And it is a problem that, that causes many things. It's not just that there's tightness in the arm, but it will impair movement. It can cosmetically be problematic in terms of how the arm and the hand is placed. It can be problematic in the quality of life and being able to dress and being able to walk properly and being able to regain the ability to run. Some people with very good function because of the spasticity can't run. And there are many treatments. So that this is what a spastic upper limb looks like. You can imagine the issues related to this, and with spasticity would be, for example, how to get dressed in this increased tone in the limb. There'll be issues related to maintaining hygiene in that hand and preventing skin breakdown. There will be pain associated with pressure on these joints and difficulties in the fingers. There will be difficulty with walking because of the posture of the hand. Why the heck would somebody have difficulty walking if we're talking about the hand? It's like if you can imagine trying to walk quickly if you're holding a bundle in your hand. Or if you're trying to run, if you're actually holding a parcel in your arm, you need both your arms to be actively moving to be able to walk and run properly. The management is physiotherapeutic. and Botox is a standard of care for managing spasticity in the upper limb. So one of the things that we need to know as healthcare practitioners when we go through the checklist is, in fact, who is able to help us with, which multidisciplinary healthcare team, OT, PT for the upper limb, lower limb, and which healthcare provider can provide management in terms of Botox treatment for spasticity. And spasticity can lead to pain. So one of the things that Amanda had, actually her major problem, she ended up, she went for a holiday in Florida, ended up in the hospital in Florida because of right-sided post-stroke pain. It was so excruciating. She ended up being admitted. I had the benefit of being able to connect with her doctors down in Florida, and we managed her with different medications. There are many causes of pain. The most common, Amanda had an unusual central post-stroke pain. That was very unusual, but there may be typical spasticity-related pain, and maybe probably one of the most common pain will be somebody who has a hemiparetic limb, upper extremity, and develops shoulder pain. It's probably by far the most common compared to all the other causes of pain. There's a nice review by Rebecca Harris and Natalia Field that reviews pain after stroke, and pain is a complex manifestation. Pain is something we perceive. Pain isn't something that we can see. There are things we can see. We can see the increased tone in the limb. We can measure the subluxation of the shoulder. We can feel the tightness of the muscles. But how that is perceived is a very complex factor for a patient. So my patient Amanda had this very complex central post-stroke pain because of the thalamic involvement of her intracerebral hemorrhage. How she felt and how she dealt with it would certainly make her pain worse. When her pain had peaked, one of the ways to manage her pain was to reduce her anxiety. There are ways to do blocks to control the pain. A lot of the most common cause of post-stroke pain is going to be shoulder pain, and there are many mechanisms in a multidisciplinary approach to manage that pain. Pain is a complex, multidisciplinary approached problem after stroke. We don't often ask our patients, and they won't tell us. One of the things that is very obvious is when you go to your local Fortino's grocery stores, you see a full aisle full of continence supplies for adult individuals. Incontinence is a major problem as patients get older, and it's a major problem after stroke, continence. So you have to ask. Patients won't tell you. They'll just go to their store and they'll just manage it as much as they can. So one of the things that urinary incontinence is probably the more recognized one post-stroke we have to ask about. At 1, 4, and 12 weeks after a stroke in this large series of patients that were evaluated, 60, 42, 29% of people will have continence issues with their bladder. If you actually do urodynamic testing on individuals immediately after the stroke, up to 85% will have involvement of the bladder. Fortunately, a lot of that does recover, but many individuals, even 12 weeks or a year out, will still have continence issues with their bladder, which we need to address and can be managed by different means. Has to be first addressed. What about bowel? Bowels are different than bladder. The bladder voids constantly during the day and you have to have relatively good control. Bowel function is something that is not as frequent and is sometimes missed. But is the bowel affected by stroke? And the answer is yes. In this prospective cohort study of 154 patients with their first stroke, the cumulative incidence of new onset constipation was 55.2% at 4 weeks post-stroke. Half of the people after stroke had new onset constipation. It's clearly associated with those individuals who have a major stroke, increased dependence, and those individuals who are using the bedpan. So take-home message from this would be, and those of us with taking care of patients immediately after the stroke, is to be aware of this. This is why in the best practice stroke admission orders, there's a large half-page bowel protocol in there. And this is why we have to, as much as possible, as soon as possible, get people out of bed and put them on a commode and put them on the toilet as opposed to giving them a bedpan. That's not the approach. Aphasia and dysphagia and dysarthria. Common things after a stroke. You have to ask about that. You can sometimes hear it when somebody's talking to you. You can't necessarily see dysphagia. That has to be communicated to you when patients are eating, that they're choking and they're having trouble swallowing, or they end up in hospital because they have a pneumonia. The question is, why do you have a pneumonia? You know, after you've been discharged with a stroke and you've recovered quite well. Are you finding it more difficult to communicate? And the thing about aphasia is that it's a moving target. When somebody has an aphasia on presentation with a stroke, what they have a year later will be very different. And fortunately, it's often better than initially. This is a patient comes in and they still have an aphasia and they say to you, is this ever going to get better? This is, you know, talking about 2, 3, 4 weeks out after a stroke. And what this graph from this very important Copenhagen post-stroke study shows is that people with a global aphasia, unfortunately, a quarter overall will end up with a global aphasia, but 15% will end up with no aphasia, even though they presented with global aphasia. And 22% will end up with an anomic aphasia, although they presented with a global aphasia initially. Those with an expressive, a Broca's aphasia, 18% remain with it, but 36% have word-finding difficulty. They go from Broca's to word-finding difficulty a year later, and 36% improve to no aphasia. And the same happens with all the others. So the take-home message about somebody with an aphasia, which you should ask if they have still an aphasia, or they ask you about the aphasia, is that there is always, it's not just about hope, but it's about actually the natural history of aphasia, that it always tends to, most of it tends to change and often changes for the better. What about dysphagia? So just to be clear, is that the Society for Aphasia for Language never uses dysphagia. Dysphagia, all degrees of language disturbance are called aphasia, although technically it means no ability to speak, but it's all called aphasia. So even a mild degree of language difficulty is called aphasia, partly because not to confuse dysphagia from dysphasia. And I hope Barb I hope she says that's correct. So in this, looking at dysphagia or swallowing difficulty, one of the things that we have, and one of the metrics to be a top stroke center in Canada, to be able to go through accreditation, is you have to do dysphagia screening on more than 90% of your patients when they're admitted. Why do we need to do that? Because if you look at Rosemary Martino, who's looked in this area for many years, they looked at a review of what happens is that if you just do a cursory, you know, how's your swallowing, people on admission up to almost half have some difficulty swallowing. If you actually do bedside testing, so a dysphagia screening assessment at bedside, more than half will have swallowing difficulty on admission. And if you actually do video fluoroscopy or endoscopy procedures to look at swallowing, up to 3/4 will have swallowing difficulty when they present to the hospital. And why is that? Why should we know this? We should know this because it is very clear from the review that dysphagia, swallowing difficulty, is correlated with developing pneumonia. And if you develop pneumonia, it's correlated very strongly with a very poor outcome after stroke. So screening for dysphagia is a best practice recommendation, and you need to ask about it and you have to screen for it. Do you feel more anxious or depressed? this is something that I think was at the forefront and people have talked about. And the question is why, and what is there something we can do about it, about depression and anxiety. Anxiety is the most common medical problem in the world. Depression probably is not far behind. And we need to seek help from healthcare providers. So what do we know about depression? In large prospective studies where we look at, this was a study looking at 9 tertiary hospitals using the Hospital Anxiety Depression Scale, the IADLS. The number of stroke patients with depression at 12 months follow-up was 21%. So 1 in 4 of our individuals potentially in follow-up will have depression at 12 months. And the other important part is that, well, there were a number that already had depression when they were discharged, but that was a small number because 16.5% actually developed depression after they were discharged, which is why it's important to do this screening, this checklist after discharge, because 16% of that 21% developed depression after discharge, not during their hospital stay. What can we do about it? Well, one of the things that was looked at, there was the FLAME study and more recent publication, the FOCUS study. And this was, it was hoped that in fact an antidepressant like fluoxetine was going to actually improve recovery after stroke. So this was a randomized trial looking at using fluoxetine to improve actually overall recovery after stroke. The study did not turn out to show that in fact it did that. So giving everybody fluoxetine did not make them recover better after stroke. But what it did show is that 20 milligrams of fluoxetine given daily for 6 months, it reduced the occurrence of depression. Now, you have to look in the details of the study because also it increased the frequency of bone fractures. It didn't improve functional outcome, but reduced the occurrence of depression. And what do I take home from this study is that in fact, antidepressants are shown in a randomized trial to actually help depression after stroke, because that literature is also very complex about the whole issue about treating depression after stroke, how to make the diagnosis of depression after stroke, and when to actually monitor and how to improve outcomes. A complex thing that requires specialty input, but it needs to be addressed because 1/4 of our patients after discharge will have depression. Thinking difficulty after stroke. This is one of those things there are that I think we should assume is always there. If somebody's had a stroke, and it doesn't necessarily have to be a large stroke, it doesn't have to be an obvious stroke, there will probably be some degree of cognitive impairment with any stroke. It's just a matter of how accurately we assess the individual. I believe that a stroke is the equivalent of a brain injury, is the equivalent of thinking problems to more or less degree. And stroke is itself a very important thing to identify and to look at cognitive impairment, to potentially screen your patients with MOCAs or more complex neuropsychological testing is very important. It's a complex scenario when we look at developing post-stroke dementia or cognitive impairment. It's a continuum. It's not one or the other. It's not normal or not normal. That's not what post-stroke is like. There are many features, and our individuals are often have increasing age and may present with already a minor pre-stroke cognitive decline. These individuals may have had a previous stroke, which has already left them with some impairment, cognitive impairment. The definition of dementia is cognitive impairment in more than one sphere. So you have a stroke, you have another stroke, you can by definition have dementia. The definition of dementia also states that you have to have a disability that's related, that interferes with everyday function. And many of our patients will develop, unfortunately, significant cognitive impairment as a result of their stroke and develop post-stroke dementia. On the other spectrum, as I remember very clearly, this younger individual that I took care of who had a pontine infarction, so a brainstem infarction. And my training as a young neurologist was always that, you know, the thinking part of the brain is the cortex and the brainstem is really not the thinking part. There won't be much of a cognitive impairment because of a small pontine stroke. The patient had a very good motor recovery, ambulatory, arms and legs, everything worked quite well, vision was intact. She never got back to work. And the reason she never got back to work is that that small pontine infarction affected her reticular activating system, and her ability to pay attention was profoundly affected at the point that she could not function because of the decrease in attention and cognitive energy. Nothing else was wrong. She could not return to work. We have to ask about cognitive functioning. We may need to expand our evaluation beyond just motor evaluation, using MOCAs and or referring individuals who are looking at going back to work with problems for formal neuropsychological assessment. Life after stroke is very different potentially. Are you finding it more difficult to carry out leisure activities, hobbies, work, or engage in sexual activity? We don't often ask this specific question. And again, I think the patients will come to a clinic and we'll say how you're doing, and that's about the extent of our specific question to patients. The one thing that people will actually talk about, and it's been shown in the literature, men will address this more often than women, is about getting back to driving. And sometimes we look at individuals and sort of and consider that, well, you know, there's so many other things to look at. Driving isn't that important. Why are they even asking me about driving? One part. The other part is I would challenge that I think many physicians are very uncomfortable in assessing our patients who have had strokes about their ability to get back to driving. A common response that I hear from my colleagues is that, in fact, well, they'll just need a driving assessment. But physicians actually have a very important role in assessing somebody for their ability to return to drive after a stroke. Our role is more complex than just saying, well, we better go get you tested. That's not the answer. Our role, as well as reporting to the ministry and providing a proper medical and functional report, is very important. Otherwise, our patient will never get back to driving. We'll talk a little bit about why that's important. So the one go-to place about driving is the Canadian Medical Association Driver's Guide, Determining Medical Fitness to Operate a Motor Vehicle. Physicians who are members of the Canadian Medical Association can get a copy of this free. Like everything else, often on the internet, if you PDF and this title, it'll come up for whatever reason available. And this manual is something you should have, you should refer to all the time. I think it is the best description of the problems that patients have after a stroke that we need to assess, and how to assess them as being eligible to return to driving, and or that in fact they may need to have a more formal assessment either by our outpatient teams, OT primarily, or by actually having to go through a complete driving assessment. This manual is also very important because it identifies, especially for physicians, about their obligations about reporting the patients for with driving issues. Not everybody who's had a stroke needs to be reported. What do I mean by that? It's like not everybody who comes into the hospital and has their ankle fractured and has a cast on the right foot, they aren't allowed to drive, but that isn't a mandatory reporting because we understand that that ankle will heal and the individual will get back to driving, although our obligation to tell them not to drive until the ankle is healed. So somebody that comes in with a very minor stroke that has an excellent recovery, or we're presuming they will have a virtually complete recovery, they don't necessarily need to be reported early on, although they may be told to not drive and they need to be reassessed. Anybody with any degree of stroke impairment, I would personally look at those individuals need to be reported to the Ministry of Transportation, and then we will deal with the paperwork afterwards. There are three major components to getting back to driving from the evaluator's perspective. Two are relatively easy. One is having proper vision, which includes, most importantly, with stroke patients, visual field intactness. And what does the ministry require? It requires a bedside review of the visual fields, just testing visual fields by finger counting and so forth. And if the patient passes, that's all they require. They don't need a formal ophthalmological assessment unless you think there's a problem, you can't be sure, and you need to assess it in more detail. The other part, which is relatively easy to assess as an outpatient, is their ability to use their arms, legs, and feet to be able to steer the steering wheel, operate the signals, and to be able to use the brake and the gas. Those are motor sensory functions on the arm and the leg. The part that's very difficult to determine about returning back to driving is the computer, the brain itself. That includes obvious things like visual inattention without visual loss, of visual perceptual problems. Those are difficulty, but also things like attention, perseveration, judgment, executive functioning, making decisions. That's very difficult to test in an examination session. We get a better idea of how somebody is when you put them on a simulator, and our OTs and the driving assessment can tell us. There are other trails, tests and so forth, and the MOCAs and things that give us information about a patient's potential problems. All of those are surrogate markers. They're all surrogate markers to the ultimate test, which is an on-road driving assessment, which is the only thing that is valid if you have concerns that somebody has difficulty with driving that you can't measure any other way. And that's where your obligation comes in to be able to do that. Now, driving is very important because it correlates with social and leisure activity. So this group looked at 145 survivors in Sweden who were followed up to 10 years after their first stroke. What they looked at was the frequency of social and leisure activities in these individuals. They found they varied considerably. And so it's not about going back to work. It's about leisure and social activities. And the things that that significantly affected a person's perception about their social and leisure activities and what they were able to do. One of them, very importantly, was their ability to be able to drive again. This is why it's important that we work with our patient to get them to drive a car if that's the appropriate thing to do. The other thing that correlates very strongly was their ability to walk a few hundred meters. A very important thing. I mean, our patients from day one, are the most concerning thing to them is getting out of bed and walking. And when they're in the community, their ability to be able to walk a few hundred meters is a very important thing to be able to get them around, get around. The other part that was very important in their overall perception of, social and leisure activity was about their social network, not being alone and having an extended social network, were all positive effects on individuals. The one that came out to be negative is those individuals who were older had much more difficulty, and part of that could also correlate with the ability to drive and their overall physical ability to be able to then walk. So they're all intertwined factors. But it's important for us as much as possible to make sure that somebody can get back to driving if they're eligible, can get to walk, and to look at their engagement in a social network, which sometimes can mean I would encourage individuals who've been living on their own who have a stroke to go to a social environment like a retirement home as opposed to going back to living on their own. Have you personal relationships with family and others become more difficult or strained? A couple will come in and they often won't say anything. I mean, everything's fine. But life changes, completely changes. And so what kind of things happen? So this is a systematic review of marriage after the transition to a stroke. So it's a major medical problem that changes people, changes relationships. So this review and synthesis of 39 studies looking at marital relationships after one partner has suffered a stroke. What they found is this narrative review is that after a stroke, initially there's this chaos that happens in the marriage. There's work to reestablish the marriage, and then there's evolution into a different type of relationship. What they found overall is about 2/3 were able to retain and regain the relationship closeness. But that means 1/3 don't. It's a very difficult time in people's lives. Some of this has been written about actually at the moment about the pandemic and its effect on relationships. As another chronic illnesses, as this paper says, the relationship closeness and a couple's ability to collaborate contributed to the survivor's recovery and satisfaction with life of the stroke survivor and spouse. So it's important to make sure that we address this, that we ask about this, that we look at potentially, if we're not doing the counseling, the family physician or any resources they may have, look at the relationship, because your patient's recovery and satisfaction in life will depend on addressing the relationship in the marriage. Fatigue is a very common problem after stroke. We need to ask about it. Patients who are, there are many things that patients are dealing with, and one of them is fatigue. And so one of the things, I think one of the studies that we did actually in our own region, when we looked at discharge fatigue being present in our own region, discharge patients, it was present in about 50% of people, decreased energy. What's it due to? Here's a nice graph showing the causes of fatigue. It's a very complex system, and which also means that we have potentials for targeting many parts of this system to be able to make people better. It's not one thing. There are predisposing factors, the person's personality, what they were like before, how active they were before. Stroke is a brain injury, like any other brain injury, which causes a decrease in energy because of the stroke itself, releasing inflammatory neuroendocrine changes. There's early fatigue after a stroke. None of our patients are running around on the ward because they have more energy. In fact, they're probably more exhausted than not. They're in hospital where they can't sleep and it's noisy, and they're sleeping on terrible beds. They develop pain, which doesn't let them sleep. They have constipation. They have bladder problems, all sorts of things that lead to difficulty with getting proper sleep and maintaining energy. And then after stroke, we've noticed, we've talked about the fact that depression develops very commonly, which itself leads to fatigue. There are residual problems with motor function. It takes twice as much energy for somebody with a significant paresis to walk than somebody who doesn't have a paresis. People lose their self-efficacy and locus of control, which decreases their internal energy. Their coping skills are important. You develop all this lake fatigue problem. So one of the things about this, and this is also maybe useful to have, is to see about what can we address to make the fatigue better. So it's not just about giving an energy drug, although there are potentially energy drugs and things that we do use, proven, not proven, really we're not there yet. Very complex factor. And then other challenges concerning related to stroke that are interfering with your recovery and causing distress. And the other challenge that I'm going to talk about in particular is about returning to work after ischemic stroke, especially in younger adults, so those under the age of 60 who may be working. And we recently reviewed this actually in Stroke Journal Club. Anybody is welcome to log into our Stroke Journal Club Tuesday mornings. And so this was a study that looked at younger individuals under the age of 60 who were working at the time of their stroke. What happens? And so there are three groups of individuals. There are those individuals who were working between 1 to 16 hours per week, those who were working 17 to 35 hours per week, and those who are working more than 35 hours per week, like most of us, full-time work, part-time work, occasional work, paid work. And what happens, let's look at people who are working full-time before work. These are younger individuals with not major stroke, but moderate stroke, who you'd think are potential good candidates for returning to work. And most of them, fortunately, do return to work. And in fact, almost half of those who are working full-time return to work full-time, and only a third or so do not return to paid work. And it's the same type of pattern: a third, a quarter, and a half who are working part-time actually return to work. So what's the point here? Well, our role is to address this with individuals, and it's not our role to say, well, you're never going back to work, you've had a stroke. Our role is to identify that, in fact, and to encourage and to realistically help our individuals with the potential to return to work. And work correlates in this study as well with that whole leisure and social outcome, and self-efficacy and well-being is about returning to work as an important factor. So that's the end of the post-stroke checklist. Every time I sort of talk about this and review this, it's one of those times where I think, well, I should really have this every time I see my patients in clinic, because I can't remember 13 things at once. A lot of this information is in the Canadian best practice recommendations. Most of all of it's there in more detail with other references. What I wanted to do is to highlight some of the key points about this. I hope that I was able to give you the holistic approach to looking at a patient. It's not point one, which is about modifying the risk factors to prevent another stroke. There are a dozen other things that should be looked at. The important take-home messages, again, being that these things are not stable. For example, remember early on I talked about IADLS, that a sixth of patients deteriorate after they've been stable, that depression doesn't show up until later, that patients will not mention things like continence, even though it's present and can be dealt with. Our job is to help individuals review what may be going on, what they may not be able to identify, and to be able to address these issues and to help them through these challenges. And to be also important, again, things like driving, that we are major individuals to help them get back to driving, and getting back to driving is an important part that leads to other things such as well-being. And those should not be taken lightly and say, well, you've had a stroke, you can't drive, as well as, well, you've had a stroke, you can't work, because work is an important part, and we do help and encourage our patients to return to work. And I'll stop there for questions. Thank you.
Thank you very much, Wes. I really enjoyed the presentation so far. Looking forward to some questions. I have 3 already in the Q&A. Please type in any more that you have, or you can put your hand up and we can ask you live. Oh, maybe you can't, not sure. So the first question is talking about dysphagia. Really, I guess it's more of a comment saying it actually isn't on the checklist. So thank you for mentioning it. And just wondering if we should be talking to Heart and Stroke about adding this to the list, because it's such an important area.
You're right. I mean, yeah, you're absolutely right. I think it should be there. And I have many patients who have come to clinic, and they just assume it's something that they have to put up with that's normal after they've had their stroke.
Thank you.
And it can be actually managed.
I have a question. I think I know the answer, but do patients fill this out or the clinician? So I've heard of it both ways.
Yes, I mean, I think it would be, again, it's going to be, it could be filled out with the patient if they have the post-stroke abilities to look at a relatively complex list of things like this. I mean, it's not necessarily aphasia friendly, this checklist. It can be filled out by, or you could be by their partners or caregivers or family members or somebody that comes with them. I find it's actually done well together with the patient during the visit. It can be done by, for example, in the stroke prevention clinic by our stroke prevention clinic nurses prior to their quotation mark medical visit, right? It should be in the record somewhere.
Another question, when do you recommend that this be completed for patients? I work in a community stroke rehab program, which is usually 8 to 12 weeks in length. So where would you see it fitting in there?
I would hope that all these things are addressed throughout the hospital stay of patients, because we are addressing all these issues. It would be important to know what issues are present upon discharge from a rehabilitation unit, for example, or from hospital itself. So it'd be nice to have a baseline measurement of all these things that may be going on. It would be nice that this record was in an electronic record that then showed up on the subsequent visits in the community or in different clinics. And then reassessed again 6 months or a year later. And the reason, so the answer is, where should it be done? It should be done at multiple transition points and at multiple times, because as we saw, for example, the risk of falling changes over time, the probability of depression changes over time, the return to driving is looked at a different time than potentially in the acute phase of hospital. The return to work is addressed at a later time. So the answer is, probably any time that you engage a patient and or their circle, this should be considered as something that would be useful.
Yeah, I agree with that. Thank you. Lots more questions coming in. From a practical perspective, how can we influence an uptake in its utilization? Because I think you did touch on this, Wes, that we don't really see it used that often, even though everyone knows about it.
So, I mean, I found it to be useful in the clinic because I printed it out and I emailed it to everybody working with me. When we moved to full electronic record in the hospital, I sort of wonder that for everybody who's admitted with stroke, somewhere in their chart, this is put in as a standard of care, that we actually can check this off, and it's done upon discharge as well. It's a recommendation from the best practice care that we use this, and I think the more of us that start handing it out, and the more people that start using it will find it useful. But it needs to be incorporated into. It's like these acute stroke admission orders. It took a long time, many years, to incorporate them, and every patient admitted with a stroke gets the stroke admission orders. This should become the same type of thing.
Great. Another question, could the post-stroke checklist be used by primary care providers? Would you see a role there?
Oh, absolutely. It can be used by everybody. It's a very, so just to give you an example, I mean, I've worked with a number of family medicine residents who are training in family medicine, who are working with our stroke prevention clinic, and I've shared this with them, and many of them, you know, and they're already working in their community practices with their supervisors, and they look at this checklist and they invariably all say, well, I'm taking this to my community practice. It works so well.
That's a really great idea. Thank you. Another question, the research on long-term care predictors of, I'm not sure what the word is, and leisure activity 10 years after stroke was really interesting. Are you aware of how much stroke patients, or how often stroke patients are referred to recreation therapy after stroke? I feel like I haven't heard a lot about it.
Yeah, no, I mean, it's, you know, we have a recreational therapist in our inpatient unit. I don't believe there's such a thing in the community. but it's it's something that really needs to be, going home and just taking care of yourself and getting in and out is not the be and end all of living. I think those other things need to be looked at, being able to get back to golfing, being able to get back together with your friends to play cards. Well, in those days, we're used to be able to get together with friends, right? That type of thing. Those things are not addressed directly, and I think they're on the sidelines.
Thank you. A couple more questions. How is post-stroke dementia diagnosed, and is this likely to develop months after a stroke has occurred?
So the most common cause of formal dementia. So dementia is actually cognitive impairment in more than one sphere, which has to, the short definition, more than one sphere that impairs with the ability to function. So even though you may have impairment and you're otherwise function normally, you don't have dementia. But if you have even minor impairments and you can't function normally because of your memory or other issues, then you may have, in fact, actually by definition, dementia. Dementia is a multifactorial, like that graph shows, of accumulated things. There are the most common cause of dementia, what we've discovered nowadays is the combination of stroke, either major or minor stroke or small vessel disease stroke, plus primary degenerative dementia, like Alzheimer's dementia. That combination is the most common cause of dementia and cognitive impairment. The diagnosis has a specific criteria. There are diagnostic criteria for it. I think it's important to identify it because it's one of those things that for families and patients, being able to make a diagnosis of that is something they can maybe understand. I found that, there was a patient that I had who I would consistently tell the family, well, because of these strokes that he's had, multiple strokes, he's got significant cognitive impairment, thinking difficulty. And after a while, I sought the resources of our geriatricians and outpatient resources. And one day the family came back with the patient, and we were talking, and they said, did you know that we met with the geriatricians that he has dementia? And the point in case being is that I never use that word. And I think in our bigger community, people sort of understand dementia and they don't understand difficulty, what I mean by difficulty thinking and cognitive impairment. I really learned a lesson there, that making the diagnosis of dementia is actually important because at least in our broader community, there's some recognition of what that is.
We have a number of questions and comments just related to social and leisure activities contributing to quality of life. First of all, happy to hear about the recognition of the profession of therapeutic recreation, and a comment about community programs being important for social recreational participation outcomes. And from March of Dimes Canada, their After Stroke program provides multiple options for individuals to get back to sports. KW has a program for modified golf. So that really seemed to be something that struck a truth with our audience.
We're all as humans looking at, we love work and we like doing things, and but we actually look forward to leisure and fun.
Yeah. So we're about at the end of our time. Thank you for all the great questions, and thank you, Wes, for this talk today. We did put you on the part of the continuum between acute and rehab, as I mentioned at the beginning, but really I appreciated how you linked the post-stroke checklist and all the transitions that patients living with stroke go through over really the long term. And we don't often really have this kind of discussion looking at the long-term recovery and living with stroke, as you've touched on today, and all the complexity and subtleties that go with that. So thank you, I really appreciated that. And I believe from the comments that our audience did as well. again, I'm going to send everyone the evaluation link, and I'll send you a follow-up email tomorrow. And I wanted to let you know that we are recording this talk, and we'll be posting it on our YouTube channel. And you can find that. I'll send a follow-up, but you can find any of the videos that we have archived from our presentations by going on YouTube and searching Central South Regional Stroke Program or Regional Stroke. And you'll see this presentation there. I would
hoping for millions of hits.
Yes, it's going to go viral, I can tell. Our next presentation will be on November 30th, so a little bit less than 2 weeks, and that is going to be an afternoon workshop talking about rehab. Specifically, it's called The Long and Winding Road, Recovery from Hemorrhagic Stroke, and we will be having 2 speakers. First, Dr. Ashkan Schwamanish, and who's one of our stroke neurologists here, and very well known in the area of hemorrhagic stroke. And our second speaker is Charmaine Martin Gaspar, who has presented for us a few times, and everyone has really enjoyed her talks. And she's a nurse practitioner here at Hamilton Health Sciences. So if you don't know about it, please contact me and I'll send you the registration information, and you should be able to find it on our website as well. I think that's all I wanted to tell you today. I'm seeing lots of appreciation and thank yous in the chat, and just commenting what an excellent talk this was. So
thank you everybody for listening.
Thank you everyone for attending today, and thank you once again, Wes, for the excellent presentation.
You're all welcome.